Hello everyone, thank you for joining this webinar on managing COVID-19 in prisons. My name is Megan Giorgio and I'm the Programme Manager for the Quality Network for Prison Mental Health Services at the Royal College of Psychiatrists. We've had a really positive response to today's session. We've got over 160 people joining us today from all over the world, which is brilliant. We have Professor Pamela Taylor from the Royal College of Psychiatrists talking through the guidance from there, and we have Dr. Caroline Watson from the Royal College of GPs sharing their guidance too. And a last minute addition, we have Mika Rautanen from Finland from the National Institute for Health and Welfare joining us as well, so an extra bonus. After each presentation, you will have the opportunity to pose questions, and please use the question and answer function within Microsoft Teams Live to be able to put those forward. We will be moderating these questions as we go through the session. We apologise in advance if we can't go through everyone's questions, but we'll do our best to get through as many as possible. We will also be sharing the recording following the event, so for anyone that you know that would like to see this, you can share that with them afterwards, and we'll be producing a summary of the questions and answers. We really hope that you find this session useful, and I'll now be passing over to Pamela Taylor, and I'll let you know, Pamela, when you are live.
Okay. Okay, thank you, Megan, and thank you everyone for joining us. If we could have the first real slide. And the next, that's it, perfect. So this is just summarizes the areas that I want to cover, why we need to maintain psychiatry input to prisons at this time, need for special safety considerations in prisons, how we can build on safe practice that we already try to institute in prisons, acknowledging that in the management structure there are considerable limits on what we as clinicians can do, how we might push at those boundaries, how we can support each other, and then I hope by that time you'll be engaged in the process and starting to ask questions and share good practice, because I think we're learning so fast at the moment that we're particularly keen to hear the good practice. So if we could have the next slide. Oh, of course I have to give a disclaimer that everything's changing, so believe only some of what I say. So yes, proper next slide, thank you. So it may seem obvious to us who are psychiatrists why we need to maintain psychiatry input to prison. We already have phenomenally high levels of mental disorder among prisoners. That's true across the world, it's not unique to the UK. There are several times the rate of all the serious mental disorders, psychotic disorders, depression among prisoners. Post-traumatic stress disorder is quite high, personality disorder very high, and of course substance use disorders. And that's a range of disorders that also tend to predispose people to a lot of physical disorders of health. And we recognise that certain disorders which are very relevant to the COVID-19 outbreak, like asthma and high blood pressure and so forth, are also more prevalent among prisoners than among the general population. So we've got a high risk population that we're trying to look after in prisons. And we need, in the UK at least, to recognise that even before COVID-19 joined us, prisons were being run under austerity, and we suffered an exceptional blow back in 2013 when prison staffing was cut by about 40% across England and Wales. The numbers of prisoners didn't change, and coterminous with that reduction in staffing, we've seen an elevation of mental disorder related problems, especially suicide, self-harm and violence to others. So we're bringing this extra burden into an already incredibly stressed system. Death rates from all causes were already rising, some of them regarded as avoidable. If you need to know more about that, the Prison and Probation's Ombudsman's site is well worth looking at. And although government has begun to recognise that and to try and restore the prison officer levels, we're getting relatively inexperienced people in post. So prison staff as well as prisoners are under ever increasing pressures. And if we could have the next slide. Megan. Okay, so this is a very important report from our House of Commons Justice Committee. That's our elected Parliament's Justice Committee. Very hard-hitting report showing how prisons are in disrepair and they're overcrowded. Distancing is going to be almost impossible in many prisons because people are tooed up, as they call it, in the cells, and cells are simply not big enough to have the statutory 2 meters apart. The total prison population in England and Wales last August was nearly 83,000, and it's not changed very much since then. Of critical importance, 13,500 or thereabouts were over the age of 50 years. Now, in prison, given all the mental health, physical health problems that I referred to, 50 is the equivalent of 70 elsewhere in the community as a very rough guide. 5,000 of those people are over 60, and the first death we had in prison from COVID was an 84-year-old man. So we've got a problem with the age of the prison population as well. Around a third of prisoners assessed reported some sort of learning or intellectual disability or difficulty. So that doesn't mean that they necessarily had an extensive intellectual disability, but sufficient perhaps to make them struggle to understand what they should be doing and so on. There were nearly 10,000 people in the mental health caseload across the prisons in England and Wales at March last year. A lot more mental disorder than that, but those were the people actually registered with services, so a big caseload. Then on top of that, we have to look at the problems, the behavioural problems that prisons have to cope with, and nearly half of prisoners in any 1 year are probably going to be involved in some sort of assault, mostly scraps between each other, but sometimes on staff as well. And I've given the web link to that report, which is really hard hitting. So then the next slide, and just gradually roll the pictures if you could, Megan, please. This gives you some idea of what people are up against. In the first picture on the left, this is a relatively well-kept cell, and you can see already that there are problems. The size of the cell means that the in-cell lavatory is right next to the place where the prisoner would put his toothpaste and coffee and snacks and all that sort of thing, and it's really not very protected. Many cells are not as neat and tidy as that, and of course many are also shared. And then the standard of hygiene throughout the prisons is not necessarily well maintained. It's so bad that House of Commons Justice Committee report includes pictures in the report of how bad it can be. And the prison inspectorate, the independent prison inspectorate, is increasingly including pictures within its reports. We have seen what can be achieved. Liverpool, which had a very critical inspectorate report, has drastically cut the number of prisoners in the prison, and a new governor has really taken a grip of the prison, and with the lower numbers and determination, that can all be improved. Next slide, Megan, please. So then the special safety considerations in prisons. Well, we've already got it in our prisons across the UK. 26th of March was our first death in England. Then in Scotland and Northern Ireland, by the beginning of the month, we were hearing that about a quarter of staff were away from work, self-isolating, not necessarily with the virus, because unfortunately we don't have testing available for them as yet. And then in England and Wales, the figures coming out, we've had 9 prisoner deaths that have been reported so far. 107 prisoners definitely testing positive, but the more important figure in some ways is that this is across 38 prisons. So that's about a third of our prison estate in England and Wales have COVID-19 already in residence with the prisoners and prison staff. Prison staff are far from immune. 3 have already died in one particularly overcrowded prison in London. And so we're really struggling. Now, as closed institutions with the impossibility of maintaining distances for everyone, the virus is going to spread, and we've got these possible strategies for reducing that. The early release programme has been much vaunted, but it's been vaunted as just that. And I think as medics, we have to keep reminding people that that's not going to help without testing and appropriate safeguards, because it'll simply move the possibility of infection from the prisons back into the community. So we really need to get this testing up and running, and we need to be much surer than try to be as a routine thing that prisoners are going to accommodation which is safe and appropriate when they leave prison. Isolating prisoners within prison, which is one of the key strategies, could precipitate, almost certainly will precipitate or worsen mental health problems. We've got evidence of that from studies where it's been done for other reasons entirely. There's another thing which is on the list of things which prisons might do, which the so-called cohorting, which is if the isolation is not feasible, you clump together the people with the suspected disorder and you keep the people without the suspected disorder in a different part of the prison. That is also going to create its own set of psychological and behavioural problems. If I could have the next slide, Megan, please. So how can we enhance safe practice in prisons? Well, we've already got codes of conduct, strategies, guidance for how we maintain safe working in prisons. And one of the key things is that we don't let all that slip by the board, because we're shifting the focus of our attention to COVID-19. And I think it's very important. One of the things that we can all do is keep an eye on what's happening. And if that established safe working is slipping in any way, letting people know about it within the prison, within the college, wherever it might be helpful to make people aware of that and turn that around. We then have to add to those standard safety measures for the proximity of COVID-19. And I think most of those now are well within people's brains. It's remote working where possible. And yes, that's possible even in prisons. We've had some experience already of that in this country, and I'm hoping some people may say a little bit about that. I think it's already happening in Finland, so we'll hear a little bit about how it's working there shortly. Simple hygiene measures are vitally important. The distancing, the maintaining simple washable clothing, keeping clothing away from the hands and lower arms, no jewellery because that can host little bugs and creatures, hand washing with soap, drying with disposable paper towels, really not rubbing hands on clothes or communal towels or those horrible hot air machines that dispense bacteria and viruses and all sorts of things through the atmosphere. Get rid of the virus altogether by washing. Basic protective equipment when dealing with examination or intervention requiring basic physical touching, bearing in mind that we're short of equipment, but we should have plastic gloves, mask, goggles, apron, and then the full protective equipment, which again is in woefully short supply. But if dealing with someone who is known to have COVID-19 or likely to be involved in any physical contact with people for whom that's suspected, then really that is vital. I think also one of the things that we have learned from work in secure hospitals, and I don't think luckily we've had to put this into hard practice yet, but is where there may be a possibility of having to practice control and restraint measures. That feels very different if you're working in protective clothing, and it's very important to essentially practice that and know what it feels like if you have to do that in protective clothing. Keep a check on your own health, and of course withdraw from service and self-isolate if it seems that infection is likely. And next, Megan. We have to recognise as clinicians that there are a lot of limits on what we can do in prisons. We're essentially visitors to the prison estate. We're welcome visitors. The prison under normal circumstances tries to work closely with us, but we do not generally have management roles in the prison. Nevertheless, we have a duty to advise, and we must advise on public health issues. So all clinicians going into prisons, psychiatrists included, must be aware of those and be in a position to advise, to help in individual care crises. And of course, for us psychiatrists, those will be mostly behavioural crises, and perhaps communication crises that people, for example, who are profoundly psychotic may find it very difficult to understand what's going on and to comply with guidance, and to be aware constantly, monitor constantly, and advise on isolating policies and how those may be affecting the prison generally, but individual prisoners in particular, and to prepare for unavoidable triaging roles. Already before COVID ever struck, we've seen situations in prisons where staff have had to choose which prisoners can go out of the prison on any one day for urgent health care. And now that's going to become even more of an issue. And I think Caroline's going to talk a little bit more about that sort of thing later. So next slide, Megan. In spite of the limits, basically, we need to be aware of when and where we can push at those boundaries. I think we're all learning things that we never thought we'd learn about remote working, and we need to make that work as far as we can in the prison estate, just as anywhere else. We need to start to draw up our own lists of where on occasion we may need to stand firm with prison staff on standards of care and hygiene and so forth, and where we have to pull out all the stops to support them. That can come in various forms. Clearly, we need to be sharing information wherever we can, where it's relevant to increasing safety. We need to be aware of when prison staff are overstretched and ways in which we might be able to help them by drawing attention to that and supporting particularly the people on the ground, and working with them when they're struggling to support us. Everything happens on the back of prison staff being able to function. We can't see prisoners in general without that, so we really do have to do all we can to support them. There may be a role for us lobbying as we recognise the various problems, and we need to think about that. One of the things that really doesn't get much attention is prisoners' families. We're beginning now to really recognise how hard it is for the families of people who are hospitalised with COVID-19, and beginning perhaps to offer little bits of support for them. Prisoners' families are already stretched to the limits very often not living particularly close to the prison. Now, of course, they won't be visiting, they will be worried, and there needs to be support for them too. And the next slide, please, Megan. So just to reiterate, recognise that any guidance is subject to continuing change as we learn more, but we do need to stand firm on a couple of things: the principle of delivering appropriate clinical care to prisoners and respect and support for all our working colleagues, whether they're clinicians or not. And next. Support for each other is an interesting and important area which we need to be thinking about all the time. Public service staff are inclined to work on regardless, and so we need to recognise that as obviously an advantage in most respects, but also a potential disadvantage if we push ourselves too hard. We strive and develop on stress per se, but we do need space for reflective practice. Even now, even when we're stressed, particularly when we're stressed, we need to reflect on what we're doing and the place that we're in and whether we could do anything better. Above all, we need to share good practice. It often emerges by accident, and we can pass that on to other people who don't have to wait for that happy accident. We can raise concerns, and that includes concerns about each other. If you really see that somebody is looking unwell or fading, to be able to help them with that and provide just basic mutual support. There will be some people relating to COVID-19 issues, and prisons will not be exempt from this, who will be exposed to the kind of extreme trauma that may precipitate mental ill health. That'll be mainly post-traumatic stress disorder type conditions, but perhaps not exclusively that. If deaths really start to mount within the prisons, for example, you can imagine that might be one such situation. And the next slide. And this is really just preparing us for moving into the next phase, which is asking questions and sharing good practice. I have a question which I'd like people perhaps to respond to, people who are hands-on out there, about whether they have had to compromise any basic security requirements or basic good practice because of the impact of COVID-19. But if there are any more exciting questions, that can always take a back seat. And my last slide we don't need to show, but it's really just about exhorting everyone to share their good practice. So thank you very much, everyone. I hope that just gets us started.
Okay, so we have 6 questions that have been published by the look of it. Can the college consider providing recommendations to look at a national rollout for Buvidal for opiate replacement treatment for prison leavers?
Yeah, well, it's a very important question, because one of the things that we most worry about is the balance of drug taking. People are very often withdrawn in prison, and there's good evidence that some, of course, manage to stay off the drugs, but many go out, take the dose of drug that they were on before they ever went into prison, and die or compromise their health very seriously. So it's very important that we can continue to manage this. I think the answer to whether the college can provide recommendations is that we can't do it today, but we could certainly look at it.
Okay, and there's a question around remote working. Do you mean seeing patients using video link or phone calls? This is already happening in Canada. 2 of our British trained forensic psychiatrists in Kingston, Ontario, previously my colleagues in Nottinghamshire Healthcare, are doing this, including assessments, treatments, etc.
Yes, I do. Now, I've seen some of the remote contact in Canada, and it's of superb quality. That would be ideal if we could get that for the short term. The only thing I would say about it is that although it's important that we have access to that, and that in a situation that we're in at the moment, it's important to do as much as we can of that, there really is no substitute for actually going physically into a prison. You cannot get the sense of what it's like to live in a prison, of what the conditions are that the prisoners and the prison staff are struggling with, unless you are physically inside that prison from time to time. And I think it probably means that even with COVID-19, some of us should be going into the prison suitably protected from time to time, so that we get that in our minds, as well as having the possibility to interview people.
Okay, in the context of a national standardised response, would a prison environment be classed as a community model or secondary care model, given that the approaches to care are very different as well as overlap, for example, emergency response?
Well, as far as I'm aware, the received wisdom has been that clinical care in prisons should effectively be the equivalent of community care. That if people really do need secondary care, that is, that had they been living in the community, they would have been admitted to hospital. That is what should happen. Now, we all know that that doesn't happen as quickly or as frequently as it should, and that prisons make other arrangements to enhance the level of support for prisoners while they're perhaps waiting to go across to an NHS hospital. But I think if we stick to the principle that the care provided in prisons should be the equivalent of good, comprehensive community care, that's where we should stick.
Okay, I'll just do one more before passing on to Caroline. Are Mental Health Act transfers from prison to secure hospitals still happening?
In theory, yes, but of course we were already in a bad place because there were long delays in them happening, and unacceptably long delays, which we've been struggling with. So I imagine that's likely to continue through this present situation, and I think it's something that as a college we must monitor very closely. There has been some reform, temporary reform of mental health legislation to try and reduce the bureaucracy required for such transfer, but of course that's not in any case in relation to transfer of prisoners the biggest barrier. The biggest barrier is finding the place in the NHS or equivalent for them to go to.
Okay, thank you. For those of you that have posed questions, we'll try and answer them at the end of the session, otherwise we'll get back to you later on. Caroline, do you want to get your screen up ready so I can put it on?
Okay.
Ooh. There you go, you should be live now.
Great, super. Thank you. It's a great pleasure to be here today, and thank you very much, Megan and Kate, for inviting me to speak about the guidance that the RCGP and Secure Environments Group have produced. It is, as Pamela said, this is a very fast-moving world, and so what was correct on the 31st of March, which is the guidance I'm showing you, the version, some of that, quite a bit of that has already moved on, and I am in the process of producing updates to reflect the changes in published guidance. Now, I've deliberately presented this as a working document because really that's how it feels. There are changes that are happening every day. So this guidance doesn't supersede Public Health England guidance. It doesn't supersede anything from NHS England or HMPPS, or indeed local operational guidance. It is informed by those. I have been extremely grateful to Eamon O'More from Public Health England and colleagues, and from Rupert Bailey, and input from the NHS team with Denise Farmer, and the whole team have been incredibly helpful in sharing work as they have been developing it to provide guidance for, as commissioners, to provide guidance for providers. So this, I hope actually I may be able to shed some light on some of those questions that were asked a little bit earlier, just from my perspective, from the GP perspective. And again, I may make mistakes on this. Some of this is my opinion, but it is largely informed by what I am living and breathing. So I think, again, I'm not going to reiterate, but I am going to go over just to walk you through the guidance. There are links. I think the links weren't working on the RCGP website, but that it has been re-uploaded now. So all the hyperlinks should now take you to hopefully useful guidance. So, for example, so important to communicate at such a difficult time for residents coming into prison, particularly hard, and we know that death rates reflect this at the best of times. And at the moment, we are asking people to come in and be behind their door and have less contact than usual. So really important to be compassionate at all times. There are a couple of links there to be able to provide information about COVID-19 in I think there's 43 different languages shared on one link, and there's some simple picture prompts which are very helpful. They were principally prepared for people with aphasia, but I think they're useful where there are perhaps to guide conversations with people who may have learning disability or maybe not able to read and understand fully the guidance that is written. So, and again, as Pamela said, remote working, it's a new journey, isn't it? And I hope it will transform, and it is transforming practice that we won't want to go back on. But at the moment we are struggling. We're struggling. There are some prisons that have telephones in cell, and that is being used well for telephone triage. There are others where they've just got the wing phones on the landing. Now, principally, HMPPS have been asked to provide a regime that facilitates people being able to be in contact with their loved ones. So there is a priority for HMPPS and prisons to provide telephones for communication, but those can also be well used by healthcare. And we've certainly been having local discussions with our prison about the importance of that. And we're getting in some spider phones so that we, and this is because I've had shared good practice by the BMA list server of other areas, other prisons that don't have in-cell phones, where they've dedicated a room on the wing where prisoners have been able to be taken to have a conversation through to healthcare. So they've been able to facilitate telephone triage and, you know, by and large, completes quite successful clinics using a single phone on a wing in a room. So I think people are being very creative and resourceful. I think it is important to say that triage should be done by someone with appropriate clinical experience, particularly where you are relying on telephone rather than face-to-face triage. So I think that we are aware that the work of Chantal Edge in her PhD is being put right on the front line and is being used to create opportunities for telemedicine in prisons across the UK. I know that HMPPS have agreed to 2 software solutions, Visionable and Involve. I suspect since I had that information, things may well have changed. But providers are currently putting bids together for commissioners to be able to facilitate telemedicine consultations, which will be helpful both for remote working from home, both for non-face-to-face consultations in prison, but also to reduce the need. We're often getting at the moment requests for telephone consultations from hospitals for outpatients appointments. Now, if we can facilitate that through a video consultation, that may be something that we will, I'm sure, all wish to continue beyond this pandemic that has triggered a change in practice. So the second section that I'm covering, it's been in the guidance, is very much about the management of residents. Again, the blue highlighted areas to remind me that although we know that the current guidance is in line with community public health guidance that people should remain in protective isolation for 7 days, I've had some comments about that in the guidance. This is the Public Health England guidance, and it's evidence-based, so that is as it remains in the UK, and it's equivalent with the community. So as Pamela mentioned, there are local cohorting arrangements being required of prisons. So a prison is required to have a reverse cohorting unit where those residents who are just arriving in from the community will spend their first 14 days to prevent transmission and to observe to see whether they develop symptoms. There are also protective isolation units where people who have got symptoms will remain, and they will remain in order to prevent infection to others. And then there are the shielding units. Now, as has been pointed out, these aren't necessarily 3 discrete areas. We had a look at our local prison and we find that 1/3 of our patients are high risk. So we should be trying to advise them, as community guidance would be, to self-isolate. We have a smaller number, although I think there are some prisons that are particularly hard hit with older populations, of patients who require shielding. And again, those where they may be able to be in a discrete, distinct area, it may be suitable for them to be behind their door, as long as the face-to-face contact is minimum, they have their meals brought to the door, the medication brought to the door, and as I say, while having exercise and phone contact requirements and showering, those are all the balance where in the community somebody may be behind their closed front door. These are options and balances and very hard pragmatic decisions that have to be made where there is the mental well-being to be taken into account, as Pamela mentioned. So there are patients who may not decide, or residents who may not decide to report their symptoms, maybe because they haven't noticed them, maybe because they don't want to go and they want to stay in shared accommodation, maybe because they are feeling hopeless or suicidal or want to harm themselves or even want to infect others. So I think we do need to bear that in mind. Those are added responsibilities that we need to be aware of. I will move on to just the initial assessment. Now, there has been a lot of talk about whether to use a particular clinical tools. About 10 days ago, it seems, or maybe even 2 weeks ago, it seems very old news now. The Roth score was being proposed, but actually that is very clearly now not being advocated. And the use of clinical judgment through careful history and questioning has been advised, and that's through the Oxford evidence-based group with Trish Greenhalgh. It's really important to remember that we will have patients with illnesses that maybe present with cough, breathlessness and fever, but also non-COVID related illnesses, and that there is an expectation that morbidity and mortality from these non-COVID long-term conditions will escalate for a variety of reasons. Now, if somebody appears to be clinically unwell and needing admission, then the use of an early warning score, NEWS 2, seems a suitable one that we've gone for, and to admit patients where there is clinical need. Now, where the patient appears to be remaining well, we need to be aware, just as with Boris Johnson, he was he was reasonable for the first 10 days and then became unwell. So is the same thing for our patients. They may begin well, they may deteriorate, and I think we need to advise them, we need to give them, and that should be part of our clear safety netting advice. We can be advising them to drink regularly, wash their hands, and have access to regular paracetamol, which, if they are a risk to themselves, either because they lack capacity to take medication or because they're on an ACT, then that will need to be an access via supervised consumption. We don't need to be monitoring people other than having given them safety advice. So that there does not need to be hourly close monitoring and we certainly don't need to be doing blood pressures. But as I say, with safety netting advice, there is always the need to take. We're at an advantage. We have got prison officers who are able to see if somebody appears to be becoming unwell, but there is still a responsibility to make sure that our patients don't deteriorate and to act in a timely way when they do. So if they do require admission, the normal escort processes will need to be followed through. If this is with a COVID-19 condition, then the officers will need to wear PPE for the escort. When a resident comes out of their protective isolation into the clinical environment, they will need to wear a mask. So once they've been through that period of isolation, it's a worry, isn't it? I realise that people are concerned because there may be ongoing symptoms of cough. Sometimes people appear to be well and then deteriorate again. But we have a duty to assess residents at the end of their 7 days of isolation. If they appear to be well, if they are apyrexial, then it is reasonable to transfer them back to normal residence. It may be that they've not actually been anywhere other than behind their door. We may not have put them in a specific protective isolation unit. So it may be that they will just be being able to come out from behind their door for exercise, for the limited regime that is able to be provided at present. So important to report to Public Health England. That is the way the health protection team will advise on the ground staff about whether swabs are indicated, and that will therefore drive whether or not an outbreak has been declared. That is my understanding. So I won't go too much into the protective personal protective equipment, but certainly there were changes this time last week, and the guidance for healthcare staff is that for all patient contact under 2 meters, not just for suspected COVID infected patients, PPE should be worn. There is a variation in choice of the PPE, and that depends on the procedure. So if there is an aerosol generating procedure, which in practice in the community, we're not really going to have that, but during CPR, that would be the time when we would be putting a gown and an FFP3 mask on. The other times, whether and the eyewear. Now, at other times, the Public Health England guidance is to have a locally informed and an individually informed assessment of risk as to when to wear eyewear and the surgical mask. So in order to moderate the use of PPE to prevent stocks running out, masks may be worn for a whole session, as can eye protection and face protection, but aprons and gloves should be changed between patients. So there are prescribing considerations. The prescribing considerations that particularly have been helpful, they've been coming out thick and fast from NHS England, but also from NICE. So just headlines: in possession, in order to cope with staff shortage, and also to reduce the risk of transmission of infection, we are being encouraged to, where it is safe, to change people to in possession medication, and where it is safe, to change that to 28 days IP. Now, in the original guidance, I wrote 12 times 28-day repeat scripts. That is because that's the community guidance. Actually, the Health and Justice Information System, it has a maximum of up to 4 months worth of repeat, but that is still often an improvement on what is done on a day-to-day basis. It is still important to have supervised consumption where this can be facilitated, particularly also checking the resident's mouth, wearing the appropriate PPE. It is a recipe for risk where we have reduced operational capacity for searches, where we have residents with more time on their hands. There is going to be increased risk behaviour and the potential for increasing diversion and possibility of drug-related deaths. So I think we need to be really cautious as prescribers to balance that need for availability of medicine, which is key, but also to keep our residents as safe as possible. simple measures are being carried out in prisons where there's tape on the lines, rather like in supermarkets, where you sit to mark out in medicines queues, so people are socially distancing. Already there's a comment in the guidance about transfer and prescribing. Now we aren't doing transfers apart from through the gold command now. That has stopped to try and minimise spread. So I won't at the moment go into all the specifics of the warfarin switching guidance that's been produced, or the NICE guidance on community acquired pneumonia. There's been some very helpful rapid evidence produced, as is the guidance on end of life medication. I will just say that when I wrote the part in this substance misuse prescribing section of the guidance, clearly there are clinical advantages and operational advantages of Buvidal, injectable buprenorphine, but at present this is not being recommended for use in community or secure environments due to operational, clinical and continuity of care challenges, and that is the view of Public Health England and NHS Health and Justice as I understand it. Now, as I say, there are also the caveat, I make mistakes daily, but that is my understanding, having checked that quite clearly. Whether there is movement, that will be a larger conversation. So I think, having said that, it is important to consider and increasing prescribing of opiate substitute treatment before release, because if we are underdosing in prisons, and we do tend to give lower doses than in the community because of the perceived lower access, if we're underdosing somebody and then they are released into the community, they are more likely to perhaps go and get a hit of heroin rather than to go to a community drug service, particularly at this difficult time where you are only allowed out for your emergencies. Their emergencies more likely to be perceived as getting heroin than going to the community drug clinic, unless we prescribe them with an adequate dose. On the question about buprenorphine, certainly the view from NHS England is Health and Justice is that once operational issues prevent safe supply of methadone, it's to say consider using buprenorphine. Clearly, it's a safe option. Given that the orodispersible version, Espinol, it's less likely diverted and more quickly administered. That would probably be the preparation recommended, but we know that people do manage to divert that orodispersible version anyway. So it's about going into prescribing with our eyes open and trying to anticipate problems before they arise. Naloxone training, if we can get that up and done in induction of residents, that would mean they've had that before they get to perhaps an unexpected release. It would also be perhaps something in this time of where everybody is restricted in their cells to consider having something like Way Out TV broadcasting the naloxone training for all residents, and then there will be a wider shared knowledge which would have to improve safety in the community in the longer term as well as the medium and the short.
Caroline?
Yes, am I running out of time?
Yes, sorry, we've just got 10 minutes left, and I think I might need to pass on to Mika.
Okay.
What I'm thinking is that for the questions that have been posed, perhaps yourself and Pamela can look through those a bit later on. If there's anything that we've missed, we can respond to in writing and include that in the summary.
Okay.
Perfect, thank you.
That's fine. So, do I need to stop completely?
If you can stop sharing your screen, and I'll move Mika on. And Mika, I'll let you know when your slides and things are on. Right. I think, Caroline, I'm not able to take you off the screen, but Mika, I think people might be able to hear you. Can you give it a go and see if they can?
So is it possible to see the slides or not? Okay, there they are. Now I can see them.
Brilliant.
Okay. Okay. Thank you, Megan. Thank you, Pamela, for invitation to join this webinar. And good afternoon to everybody. And Nordic greetings from Finland to everyone. I'm very briefly telling you about situation in Finland. I'm working in our healthcare services for prisoners as a forensic psychiatrist, and here I have some notes in a couple of minutes for you to see how things are going on in Finland. Next slide, please. Okay. There are no COVID prisoners in Finland so far. 3 staff members are infected, but luckily from administrative and teaching units far away from our prisons. We have taken quite heavy restrictive measures already. Prisoners, they have no leaves right now, no visitors except official ones, the police, lawyers, interpreters. The activities are quite minimum now. Canteen, gym, libraries, jobs are closed, and only very important reasons are left for transferring prisoners between our prison units. Practically, there is no traffic left. We have 3,000 prisoners altogether in Finland every day, and now this number is decreasing because according to new rules we have, if a new sentence is a short one, not more than 6 months, so it will be postponed and it will start later in the autumn. So when we calculate this, there will be around 400 to 500 drop in daily count of prisoners until August, because there are no new coming prisoners during this first months of pandemia. Okay, next slide, please. Our healthcare services now handle only acute or subacute health-related cases. And if COVID is found, so then this prisoner goes to quarantine or kind of isolation for 7 days plus at least 1 without symptoms. And nurse needs these patients every day, according to our plan. So far, we have only had 3 cases, and they proved not to be COVID ones. Lack of equipment, masks, and PPEs is surely coming, and the training and using of those is not easy, so we need to practice. Should there be one case, so after that the whole prison ward will be tested and every prisoner in that ward have to be taken care of. And if someone's situation is getting worse, so then we need to transfer these prisoners to public hospitals. We have remote contacts, video links, daily. They were routine already before this pandemia. We use business Skype or Link. They work very well. I can recommend those things warmly. And we have different remote applications for GPs, general practitioners working outside our prison healthcare, because we have 27 prison healthcare units all around our quite big country, and distances are long, so these things work pretty well already. We try to work very closely with Criminal Sanctions Agency okay, next slide, please. We have started an administrative level kind of pandemia board meetings twice a week with Criminal Sanctions Agency, and that feels very needed and good, because wrong information is everywhere right now. For instance, in one prison, they started to put prison mail in quarantine for 2 weeks before delivering it to patients, to prisoners, in fear of virus spreading via mail or post boxes. Of course, there is no real need for that, but then healthcare could advise in that situation the criminal sanctions staff, and that issue was solved. We have local meetings with doctors and prison heads once a week in our 3 bigger areas, and we have a health-related bulletin or information sheet updated sometimes per week, and it is delivered to everyone by our intra or emails, and not only to healthcare but also to prison staff members, and simple and graphic information of protective measures and so on. We have information for prisoners and their close ones in different languages in the web page. That is something to recommend, of course. And if a prisoner gets the virus and the situation getting worse, of course, media is immediately asking many questions. So someone must be in response of public relations at that point. That is sure important. And I think also it's a good idea to do something, to give for the staff something to do while waiting this situation either to escalate or to resolve. So it is a good time to get certain things done. And then the final slide, please. I think that the key issue here is to give good information, to communicate clearly, and encourage our staff. And no matter we face mistakes, we have to understand those things, and we have to be clear and correct to outside in our communication. That's the key issue here. I think we can do this. We all take care, and we have you all there that you have stamina and resilience, of course. So I think we can tackle this. So this, in short. Thank you very much.
Okay, thank you very much. So we have hit 1 o'clock. Pamela and Caroline and Mika, if you want to keep your microphones on, do you want to just answer a couple of questions before we go, or do you think we should finish up?
Your hands, Megan.
Okay, so I'll just put a couple through. So there are some questions around confidentiality in terms of speaking with people on prison phones within their cells. There's some issues there. One question around, do you think IAPT is considered an essential service in UK prisons, and should their services continue given the crisis?
So confidentiality is clearly an issue. It's an issue in prisons anyway, because we have to have good enough ability to share information appropriately with prison staff anyway. Now, I think the question was arising because of the extraordinary conditions in which we may need to be talking with prisoners, and that it's entirely possible that we may be shouting through a cell door. I mean, that's already been true before COVID, that when staffing was at exceptionally low levels, prisoners couldn't be brought across to healthcare. Psychiatrists were going to see them and then found that they couldn't be unlocked. So yes, it's a serious problem, and I'm not sure that I can say anything much other than acknowledging that it's a problem, and that we're not going to get quality sessions with prisoner patients by that route. We're just going to be able to see the tip of the problem, and that's all. So we need to be very careful about that. IAPT, difficult one. I think one of the things that is most important for us is that it's undoubtedly going to be the case that from time to time we'll find that some services or some conditions are temporarily less important than others. So that just as it may be more important to speak to a prisoner at all, even if you're having to shout through a grill, than not to speak at all. So it may be that if all the services are stretched, there might be some give in IAPT, although given all the stress I think that prisoners are likely to be feeling, I think we should be very cautious about that. Whatever we decide in the crisis, we must be sure that it's a measure for the crisis, and have a proper review at the end of the crisis as to which things that we've learned during the crisis that it would be helpful to carry over. So I think several people have made the point that we could make possibly for more efficient practice by making much more use of remote facilities, providing we can get all the safeguards good enough on those. I still think we want to emphasise that although we could make more use of them, we don't want it to be a complete substitute for what we should be doing, which is going into prisons from time to time. And there are other things, like if we did have to suspend IAPT at all, that it's clear that that's a suspension and that normal services will be resumed as soon as possible.
Okay, I'll just put one last question out there. A colleague from Scotland has said that they haven't yet started early releases. One of the concerns is about the ability of people to adapt to changes in the outside on release. In addition to this, the difficulty accessing face-to-face support from different agencies, prescriptions, seeing family and housing, and they'd be grateful for any advice.
Well, the measures that we are taking to help with from the prescribing point of view, certainly we are changing from what is normal business, which is 7 days of TTOs, 7 days of prescription. We're changing to have the capacity to, or to have the capability to write FP10s, or the Scottish equivalent, of for 28 days. For opiate substitute, so on the FP10 NDA, the blue scripts, we would be doing up to a 14-day bridging script. That is a guidance that is coming out from NHS England Health and Justice. So there is some capacity to ease that transition. We appreciate though that that's just one element of a very complex transition.
Okay, so I think that we will end that there. So I'd just like to thank Pamela, Caroline and Mika for taking the time to provide this advice and guidance for us today, and we hope that you found the session useful. We will be sharing the recording and we'll produce a summary of the questions and answers, like I said, following the session, and we'll try and get Pamela and Caroline to provide some extra information on those we weren't able to talk about today. Just to let you know, we will be looking at running some future webinars, so we will be in touch shortly with other things that you might find interesting. And the Royal College of Psychiatrists, and I believe also the Royal College of GPs, have online platforms for managing COVID-19 that you might find helpful, so we'll include those within the information we send you as well. But thank you everyone, and stay safe.
Thank you, Megan.
Thank
Bye.
you.
Thank you.
Thank you.
Bye.
Thank you.